Thank you, Dan. That was pretty eye-opening when you actually start tallying up all those numbers, and with Margaret telling us where those numbers are going. You know, we have a lot to do this year in Sacramento. Even as we work on things in Washington, there's a lot to do in Sacramento. And someone who's been doing a lot in Sacramento recently over the last several years, building a completely new system out of whole cloth, is Lance Lang. Dr. Lang is the Chief Medical Officer of Covered California. And we have the pleasure at Molina of working with him on a very regular basis, and a true leader in his field in terms of trying to change the culture of healthcare in our state. I'm amazed at the strides we've made, and I also know, thanks to my contract that we signed recently, that we have a long way to go as well. So in partnership, Dr. Lance Lang.
Well, this is my first time at this conference. It's an awesome meeting. Thank you for inviting me. I've got a lot of hard acts to follow, including living up to the praise that many of the earlier days speakers made to how California's implemented the ACA. And so what I'd like to divide my time in 4 parts. One is to kind of show you a little of what we mean by our success, just with some numbers. Second, describe a little of how we got there. I'm a family doc who got boards in geriatrics and still delivered babies and went into administrative medicine. I haven't, since grade school, been able to narrow my topic. But I'm going to try to be a little disciplined in the way I approach that. Third is to talk a little about what we're now doing now that we have 1.5 million folks on the exchange and another 700,000-800,000 off exchange in mirrored products. So that's our risk pool, is the combination of those two. There are only about 10% of the individual market in non-mirrored products. And then finally, without getting at all into repeal and replace, I want to talk a little bit. There's a proposed stabilization regulation. So for how we might manage 2018, that's real. It looks like I've got a job at least through 2018, which is a big relief. I think trying to explain what that's about, and because based on the earlier discussion, we may be living under that regulation for quite a while. So let me proceed. So here's what's happened to the uninsured rate in California. It's pretty impressive, and I think does deserve the praise earlier. Here's how it compares to national. We started out in 2013 with a higher uninsured rate than nationally, and we're now lower. So I think it's very impressive that there's 5% fewer uninsured nationally, 5-6%, somewhere in there, but 10% lower here. And that's what I think people were trying to talk about the success in California. This outlines a little how that happened. And let me start at the bottom in the blue, which these numbers are out of date. And one of them, this shows a slight decrease in the employer-sponsored market. I don't believe it. And there was a slide earlier, I think it was Joe, who showed it that to kind of poke holes at the success of the ACA, saying that there were 12 million in the exchanges and there was projected to be 20 or 22 million. The difference is the stability of the employer market. so that we've been successful in addressing those who were previously in the individual market or uninsured. What we haven't done is there's nothing about anything about what's happened in the last 5-6 years that has stopped employers from providing insurance. And so that's the difference in terms of why we aren't hitting the original projections there. It's not a failure. In fact, I mean, anyone can, you have to make a value judgment of whether we should have employer-based insurance. But if you value employer-based insurance, there's no failure here. We've attracted those who were most in need, and that's how we've lowered uninsured insurance. So where it's most out of date is where in Medi-Cal, where we started with 9 million and are now at a little over 14. I think it's 14.2. It's hard to keep up. That's just an enormous success in and of itself. And I think we all can have pause in the context of the discussion earlier today about having that many people meeting a definition of 138% of poverty or less in the state. And that's a big deal. So what we've addressed is the individual market, which is a way station. It's people who either just got a better job, have a higher minimum wage because that's what's happening in California, and now qualify for our product rather than Medi-Cal, or who've lost their job or who want to take a risk and start a new entrepreneurial business. And about a third of our membership are entrepreneurs, self-employed folks who are starting new businesses on their own, which is something we're quite proud of. And we actually think there's some folks on the right-hand side of the aisle in Washington who might praise that. At any rate, we've gone from about 1.5 million in a very unstable individual market before to now about 2.5 million in an individual market. So that's an expansion of the market and a stabilization. We have the essential health benefits now for all those folks. And our rate of price increases, the first 2 years was just 4%. Most recently it was 13% on average, but was divided. There were two plans who have bigger brand names and attracted probably higher risk. And so I think the description earlier of a need for correction occurred for those two big PPO plans that were statewide. The others were under 8%, and they cleaned up. Oh, Joe, you're back. I just was dissing one of your slides. So, at any rate, we're in that middle space there. We've now served over 3 million folks because it is an unstable market. 9 out of 10 are on subsidies. There's about a 30% churn every year. And of that 367 billion, we're about a little over 6, so 2%. But we think we have a little more influence than that. So this is how it spreads out across the state. We have 19 pricing regions. And there was discussion earlier about having choice, but not so much choice as to confuse people. And we really strongly believe that that's important. So there's no place that has more than 8 options to choose from. So in talking about how we got there, we take 4 roles. One is as what used to be called an active purchaser. That's no longer quite as de rigueur or politically correct. We build standardized products that are affordable. We take a large part of the marketing effort as related to this. Half our budget goes to marketing. And then my job on the right. As best I know, this is the only exchange that has a chief medical officer or as broad an agenda as we have about delivery system reform. And so that's what I want to do next after I finish talking about the part about building affordable products, because I think that's really important. And one thing before I leave this I should say is that the reason Margaret's discussion of the state budget didn't include the exchange is that we're not on the state budget at all. There's no general funds that go to the state budget. Our budget after federal startup dollars comes exclusively from a portion of the premium that's paid, combined subsidy and the consumers. So we have over a year's worth of dollars in the bank. We don't ask for anything from the general fund. We're independent. And I should point out that that structure was set up under a Republican governor. We don't actually report to the current governor. We have an independent board. We're well funded. We have a lot of autonomy, and I think it works pretty well. So this standardized benefit structure is something important to understand, both because of how it works now and how it will work under the new reg that I'm going to talk about toward the end. There are 4 metal tiers: bronze, silver, gold, and platinum. There's like 5% of our membership in gold and platinum. So the action is mostly in bronze and silver. There are actually 4 levels of silver, as those who asked about the cost share reduction earlier and the lawsuit that's now House versus Price. Those are built into the law but not funded. What would be a health plan responsibility if the government didn't pay that cost share reduction? That would not be a popular thing or anything good for rates or premiums if the plans paid that. But there are several ways in which not just the premium, but the copay and deductible costs of patients are reduced at the time of care. It's a very efficient way of getting money to those who actually spend it, rather than just subsidizing premium. So it's really good that that's been deferred and apparently taken off the table as best we can tell, and a big part of stabilizing the markets going forward. But this is Peter Lee's slide and his heading. How you structure it, let me back up. There have been several efforts to interview Trump voters who also are getting coverage on under the Affordable Care Act, to understand what were they thinking. And the Kaiser Family Foundation has probably done the most extensive interviews, but Sarah Cliff, who's a journalist for Vox.com and who is spectacular in explaining things, also interviewed folks in Eastern Kentucky. And universally between all of those focus groups, they took Donald Trump at his word that he was going to fix health care. And what they meant by that was what he's still saying, which was better benefits at lower price. And what they were most upset about was the high deductible. And we've been upset about the relative difficulty of the bronze and silver, especially, plans in terms of how do you make that still useful to folks. And so we've adopted a value-based benefit design that excludes ambulatory care from the deductible. So that people pay their copay, but which is generally $35 or less for primary care, but they don't have to meet the deductible. If providing health insurance to folks if you want them to get care, you can't create a barrier between them and their primary care experience or their ambulatory care experience. And that's true for, that's also true for mental health, which is included in that, and it's true for specialty and for urgent care. ER is treated differently. But we have all of our products have at least some ambulatory care, including bronze, where there, in addition to the wellness visit, there's 3 additional visits excluded from the deductible. All silver and above, it's all ambulatory care excluded from the deductible. And this is critical. And I'll come back to that when I talk about how we manage some of the new regulation, or how we might if we haven't fully decided yet. That's not true in other states, and that's part of the dissatisfaction with the ACA, we think. This just compares, and it addresses both this issue and the number of products. In Seattle, if you have 50 silver plans, that's going to be a very difficult decision for relatively uninformed consumers to figure out what they want to pick. And we think there's evidence that people make decisions that aren't good for them in those settings. This just basically makes the same point. So I'll move on to, so what are we doing with this, and why have a chief medical officer in a quality program at an exchange? And really, from day one, I came a little less than 2 years ago, but from day one, there was an attachment to the contract between Covered California as a purchaser, like an employer, where we purchase health care, and all the qualified health plans, saying delivery system reform and quality improvement was part of the deal. All we did the first few years while we were building a market was to ask, so here's a list of areas that we think are important. What are you doing? And we collected that information. My job when I arrived May 2 years ago was to take all that information and work in this really terrific multi-stakeholder process that we use to develop that benefit design I described earlier, where we convene the plans with the consumer advocates, with the providers, and with the academics all together in one room, and we talk through how we're going to work this stuff together. And so we had established that process. I inherited it, and it works beautifully, and that's how we came up with our benefit designs. It wasn't all, Peter certainly had ideas, but he didn't just say, this is how we're going to do it. Many of you have worked with Peter before, so I can take his name in vain. So we took all that information. We also talked with, or took information from the CMS Innovation Center, CalPERS, DHCS, which manages Medi-Cal, and Pacific Business Group on Health, which is the aggregation of employers, so that together we represent 17+ million patients, to see if we could coordinate our expectations of the market. I think variation in practice starts with purchasers, with different expectations of the delivery system, and so we've just started, but we're getting there, and we really encourage multi-payer collaboration. I couldn't be doing my current job if I hadn't spent 9 years at a health plan previously and experienced the frustration of talking to hospitals about quality and being told that's none of my business. Because there's no plan in California that's more than 10 or 15% of the market. But if we work with 11 health plans, that represents almost the entire market. If they're all on the same page, then there needs to be attention paid by across the delivery system. And so those are the principles around that we've tried to work with. Plus the issue of managing all this stuff together so that quality and reduction in variation is aligned with the contract, is aligned with network design, is aligned with payment design in terms of how providers are paid, so that all of that is interwoven. And so that's what I've been trying to do. And we've come up, there's a requirement in the ACA that any qualified health plan do a quality improvement strategy, and it's basically a pick list. We said those are all good things. And the folks from Molina and Shield will attest to the fact that I think they all agreed. And the cool thing was the feeling that I think there wasn't a asymmetric investment in a market where it's so fragmented. If one plan doesn't want to get too far out ahead of the others and let the others draft on their efforts. So if everyone could agree that these are important things to do, and we all did it together, then there was no plan taking advantage of others' investments. And I think that's critical to a state as big and complicated as ours. So this is what we've been working on. We've been promoting integration and coordination of care through advanced primary care designs, patient-centered medical home, and accountable care organizations. We're encouraging, and we have, as of next week, on the 1st of March, all California enrollees will have a primary care physician. And that's brand new. It includes the half our market that's PPO. We've made we thought about renaming the category of primary care physician because of the mix-up with gatekeeper. I often say that I didn't know anybody in my class when I went to be a doctor or a family doctor whose burning ambition was to be a gatekeeper, and applied to medical school on that basis. And patients sure didn't like it. And we have a lot of folks at Covered California who thought I was crazy talking about this stuff. But we've reclaimed primary care physician as a good thing, and not a barrier, but actually an advocate and a first point of contact, and that's what we're working on. It's we'll find out later how it went, but it's sure to be a little messy. We've tried to do it through attribution. There'll be mistakes made. When we first notified patients, they basically said, "I already have a primary care doc, leave me alone." So there's a lot of communication that needs to be done about that, but we're getting there. We're going to layer on payment reform, and I hope it'll look something like the CPC Plus model, if you know that or what the LAN work that's going on, Learning Action Network, and nationally. And then we're going to ask plans to get a growing number of their enrollees into practices that have been recognized as medical homes. We're taking advantage of information we have about the racial and ethnic mix of our population and tracking quality scores by ethnic and racial mix. So tracking, trending, and hopefully improving and narrowing the gap. I mentioned the payment for primary care. ACOs have a payment reform embedded in it with accountability across specialties and institutional boundaries for the triple aim. And for maternity, we've asked that there no longer be an incentive to do a C-section. For hospitals, we're asking that every 2 years that another 2% of reimbursement be tied to quality outcomes. So we have a payment reform tied to most of our work, and it aligns with the quality goals. And lastly, we're looking at variation where data is available, and that, unfortunately, for hospitals is in hospitals. And this is just the low-risk C-section rate. And you'll see that it ranges from 12 to 70% in our state. So that kind of variation is what we're trying to address by asking plans to say, by the end of 2019, we have a 3-year contract that just started. We want any hospital that's not meeting goals, and we still haven't defined what outlier performance is. It's not going to be rigid right at the target, or at least moving in that direction. And we'll accept both attainment and improvement. Betsy DeVos has gotten an education in addressing both attainment and improvement, although education uses different language. But that kind of performance on the right tail, we don't want those hospitals in our network. I've been talking to every hospital association and many boards of trustees at hospitals to help explain that. It's an improvement project with a deadline, not a narrow network strategy, though, because there is improvement available. California Healthcare Foundation is funding a program that any hospital can sign up for free to adopt policies that have been piloted that work to lower low-risk C-section rates. So there's no reason not to improve that. I'm not showing you, but a similar curve that looks just like this is available for all hospital-acquired infections and other complications. And we have probably the definition of an outlier poor performer will be those who are out on the right on multiple of those and not improving them. So that's our quality agenda. We think that that'll drive improvement over time, and it'll achieve this kind of outcome where, like Michael Pollan's efforts on diet, that we can do the same for medical care, where you get medical care, not too much, and mostly primary care. So really briefly, can I take a couple more minutes to talk about, there's the 72-page proposed regulation for 2018. And if I can boil that down to 3 buckets of the biggest changes. One we were already working on, and that's doing a better job of documenting that people who come in for special enrollment actually qualify. And there's an automated way of doing that. We think we can hit the right balance between not subjecting plans to undue risk, but also not creating a barrier to getting insurance. And that's the balancing act that you've got to do, and we think we can do that. We think that's reasonable, and it's in the reg for 2018 across the country. The Obama administration was moving this direction. They were going to pilot it. They've moved it up. The second change is to shorten open enrollment from down to just a month and a half, from November 1st to December 15th. We can't, for the life of us, really understand why. It might make it more predictable at the beginning of the year what your population is as a health plan. Maybe you guys can help me understand this, but it also, as was described earlier about the marketing at the tail end of enrollment, that it's healthy people who come in at the end. So the folks who are, it's going to be very hard to squeeze. We enrolled 412,000 new folks this most recent open enrollment. Getting all that done through the call centers, through the IT systems in 45 days is going to be a bear. It can be done. We'll make the best of it, but it will probably leave healthy people behind. So we'll have fewer people signed up and a worse risk pool. And we just don't understand why you do that. The third thing, which fits with the election commitment to create more affordable, which means less expensive plans, is that the AV calculation of the metal tiers is hard to get precise. So it's always had a flexibility of plus or minus 2%. The proposal is to expand that to +2 -4 for most of the metal tiers, and even wider for bronze, including a +5 option. If you do that in silver, and I'm taking this more from what I read in the press than from our internal deliberation. If you do that in silver, you reduce the premium, the advanced tax, APTC, the advanced premium tax support. So that's an important thing to try to avoid. And so we're looking at ways to leave silver alone, basically, and we probably will implement changes to the others, but we've got a lot of discussion to go on that. But that's a worrisome approach. We have more ability to manage through that change in AV because we have standard benefit designs. So that's why what I wanted to come back to is that all the plans will implement the same thing. We do need to make sure we think about, so what opportunities are there that are non-mirrored that might undercut our risk pool? My apologies to my colleagues as to what we got to think through what they might do separate from what we do, but that's also in the mix, and so that'll be part of what we think through. But those are the three big changes. There will probably be fewer folks enrolled in 2018. There'll probably be a moderately worse risk mix based on this regulation if this is what gets implemented. But it'll still be here. So could be worse, I guess. So with that, I'll take questions later, but thank you for the time. It's been an honor to be part of it.